It's one of the very, very common drugs. These are one of the very common drugs which are asked in your Viva VOC. And we will be talking as per the Viva which you are asked and you have to answer. So starting, these are 4 drugs we all know: propofol, thiopentone, etomidate, and ketamine. So I'll be starting with propofol. So when you pick up a drug, the first thing the examiner expects you to answer is identify and describe the drug. So just not identify, but describe also. So you will say this is a vial of propofol. It belongs to the alkaline phenol group. Its chemical name is 2,6-diisopropyl phenol, and it comes as a milky white lipid emulsion. Then the next question is, this is a milky white solution. What are the constituents of this commercial preparation? So this comes as a 1% solution. It contains propofol 10 milligrams per milliliters, 10% soybean oil, 2.25% glycerol, 1.2% eglecithin. Then it may have EDTA or metabisulfite. EDTA in a concentration of 0.05 per ml and metabisulfite in the concentration of 0.025 milligram per milliliters. Then once you answer these commercial preparation constituents, the automatically examiner is bound to ask you what is the role of all these constituents. So soybean, it is a lipid vehicle to carry the propofol. Glycerol, it maintains the solution to the isotonic blood. Eglecithin, it stabilizes the propofol soybean oil droplets in the aqueous dispersion. Then EDTA, it is added to make the pH of 7 to 8.5, and it retards the microbial growth. Similarly, sodium metabisulfite is also has the same role, but the pH maintained with the propofol, which has sodium metabisulfite, is 4.5 to 6.4. So what is the mechanism of action of propofol? It is, we all know, all IV induction agents, they act through the activation of GABA receptors. This GABA is the inhibitory neurotransmitter, and there is an increase in the transmembrane chloride conduction. So there is hyperpolarization in the postsynaptic cell membrane, and there is functional inhibition. So almost all etomidate and thiopentone also act through the similar mechanism. So coming on to the pharmacokinetics. By pharmacokinetic, what do you understand? That how the drug is metabolized, what is the onset, what is the elimination. So propofol is metabolized in liver and excreted through kidney. There is an evidence which shows that 30% of the drug is also metabolized in lungs. The elimination half-life of propofol is 0.5 to 1.5 hours, and the context sensitivity half-time is up to 40 minutes after continuous infusion of up to 8 hours and 10 minutes after the bolus induction dose. What is the onset? It is 40 to 60 seconds, and duration of action is 3 to 5 minutes after the bolus of IV propofol. So then once you have answered these things, the examiner can ask you, what is the endpoint of propofol induction? When you give propofol, what is the endpoint of induction? The endpoint is loss of verbal response. That is how, when your consultant or your senior resident is giving propofol, he or she may ask you to talk to the patient. Why? Because you want to assess when there is loss of response to the verbal command. The next most commonly asked question is, why is propofol most preferred IV induction agent? Then the answer commonly answered is that it gives a clear head recovery. Once you say this clear head recovery, the examiner will ask you, what do you understand by clear head recovery? By clear head recovery, you mean that there is minimal residual. The patient gets up fresh as nothing has been given to the patient. So what are the various doses? When we are talking about induction of the propofol, induction through propofol, what are the various doses? The dose in adults is 1.5 to 2.5 milligram per kg. And in children, this dose gets, it is higher doses are required in children because of the higher metabolism through the liver and the greater volume of distribution. Then for sedation, propofol is used as a sedation drug also. The dose is 25 to 100 microgram per kg per minute. Propofol is also used in total intravenous anesthesia with the dose of 1 milligram per kg as a bolus, followed by 10 milligram per kg per minute for 10 minutes, then followed by 8 milligram per kg per minute for 10 minutes, another 10 minutes. Then they're on 6 milligram per kg per minute. Then propofol also, apart from its sedative property, it also has an antiemetic property in the dose of 10 to 15 milligrams stat bolus, and antipruritic property also as 10 to 20 milligram bolus. So what are the systemic effects of propofol? So when we are talking about systemic effects, we start with the cardiac or the central nervous system. It is a cardiodepressant drug. So there is cardiac myocardial depression action is there, peripheral vasodilatation is there, decrease in systemic vascular resistance. Hence, there is decrease in cardiac output, heart rate, and blood pressure. In central nervous system also, it decreases the cerebral metabolic rate for oxygen. It decreases the cerebral blood flow. It decreases the intracranial pressure. In lungs, it depresses ventilation, so there are high chances of patient being apneic after giving propofol bolus, and also it has a bronchodilatory property. Hepatic and renal, if used as boluses, not much of the changes, not much changes there. But if prolonged infusions are used, then it is associated with hepatocellular injury, and sometimes green urine, that is phenol presence, is also noticed. Intraocular pressure that is also reduced with propofol. So after the systemic effects, obviously the examiner is going to ask you what are the other effects apart from the systemic effect. What are the most common side effects of the propofol? So the most common side effect of propofol is pain during injection. Okay, so how do you attenuate this pain during injection? You give a bolus of lignocaine prior to the injection of propofol. You may give opioids, and you may use a bigger vein to eject propofol. Small veins on the dorsum of the hand, they usually have higher incidence of pain during propofol injection. The next side effect is most commonly asked propofol infusion syndrome. What do you understand about propofol infusion syndrome? It's a cascade of clinical signs and symptoms. If the propofol is given at the dose more than 4 milligram per kg per minute for more than 24 hours. The syndrome includes rhabdomyolysis, metabolic acidosis, cardiac failure, renal failure, a triad of hyperkalemia, hypertriglyceridemia, and hepatomegaly may be observed. The other side effects of propofol are allergic reaction. It has an abuse potential also. A vial once open should be used within 24 hours because it can support bacterial growth. And it has antioxidant properties also, so it can actually cause reperfusion injuries also. So that was all about propofol. Coming on to the next drug. So this is the drug. Again, identify and describe the drug. So this is a vial of, or the ampule of etomidate. And chemically, it is carboxylated imidazole containing compound. It is water soluble at acidic pH and lipid soluble at physiological pH. So the commercial preparation again comes as a milky white solution. It has 35% propylene glycol. The pH of the solution is 6.9, and hence it contributes towards the pain during the injection. And the preparation is 2 milligrams per ml of etomidate. Mechanism of action is same. It through the potentiation of chloride currents mediated through the GABA receptor complex, and the functional inhibition is attained. Pharmacokinetics, main metabolism is in liver by hydrolysis, and it is excreted 78% via kidney and 22% via bile. Elimination half-life of etomidate is 3 to 7 minutes, comparable to propofol, and one arm brain circulation is 30 to 60 seconds. And induction dose is 0.2 to 0.4 milligram per kg. So now the new phrase has come, one arm brain circulation. It is important in propofol context also. You may be asked, what do you understand by one arm brain circulation? So it is defined as the time taken by the drug from the injection site to reach the brain. So it is more or less coincides with the onset of the action of the drug. So propofol and etomidate both have a very short one-hour brain circulation, 30 to 60 seconds. Again, same thing. What are the systemic effects of etomidate? Cardiovascularly, it is the most cardiostable drug in the dose of 0.3 milligram per kg. It has a very minimal cardiodepressant effect. And in central nervous system, it causes cerebral vasoconstrictor and vasoconstriction and decreases the cerebral metabolic rate for oxygen. Then cerebral blood flow is also decreased and intracranial pressure is also reduced. There is on the long term, if etomidate is used as a treatment for long-term intracranial hypertension, it also causes adrenocortical suppression, which is the most common side effect, you can say, or it is the this adrenocortical suppression is very responsible for etomidate not being used commonly. And then EEG pattern, the suppression is also like propofol and thiopentone. What are the other effects of etomidate? Then pulmonary ventilation depression may occur with the etomidate. Etomidate injection administration also causes pain on injection. This can be eliminated with the use of lipid emulsion vehicle rather than using propylene glycol. Then the most common side effect of etomidate is also myoclonus. It happens in 50 to 80% of patients, and prior administration of benzodiazepines or opioids may attenuate this myoclonic effects. So what happens is when you give etomidate as a bolus for induction, you see these small fasciculations. Sometimes the jaw is locked so much that you are not able to ventilate the patient. So these myoclonus are unwanted side effect of the etomidate. And adrenocortical suppression, as I already told you, that there is a dose-dependent inhibition of 11 beta hydroxylase, which is required for conversion of cholesterol to cortisol. So these are the common side effects of etomidate. Coming on to the third drug, again, identify and describe the drug. How do you describe? This is the vial of sodium thiopentone. It is an ultra short-acting barbiturate. It comes as yellow hygroscopic powdered formulation in a vial of 1 gram or 500 milligram. The pH of this solution is, this drug is 10.1. It's a very high pH. It is reconstituted with normal saline to make it as a 2.5% solution, that is 25 milligrams of thiopentone per ml. So the thiopentone is associated with lots of questions, though many institutes are not using thiopentone, but thiopentone is the drug of choice for many examiners to ask. So you should be thorough with thiopentone. The most common question which is asked is that why is it yellow in color? It is because the thiopentone has a sulfur molecule. So the sulfur molecule is responsible for its yellow color. What is the mechanism of action? Again, potentiating the GABA A channel activity. It is similar to propofol and etomidate. Pharmacokinetic, it is a rapid awakening and rapid onset and rapid awakening. Loss of consciousness is there in 30 seconds. Rapid uptake is there. Then rapid redistribution out of the brain into the inactive tissue is there, which is fat and muscles. So what happens once the peak is reached and after the redistribution, the peak declines because of the metabolism. Then the peak concentration in the blood is less and the concentration in the fat and muscle is more. So the drug travels from fat and muscle again into the circulation. So there is re-entering into the circulation and the blood levels are again maintained. So there's a long context sensitivity half time. So the drug actually lasts for a longer duration. There is resedation after the rapid awakening of the patient. Metabolism of thiopentone is through hepatic mainly, and it is excreted through kidneys. So the intravenous induction dose of thiopentone in adults is 3 to 5 milligram per kg. In geriatric population, you should decrease the dose by 30 to 40%. And in pediatric population for children, it is 5 to 6 milligram per kg, and in infants it is 6 to 8 milligram per kg. Why this increase in dose in children and infants? Because they have a higher volume of distribution and a higher hepatic metabolism. So what are the systemic effects of thiopentone? Again, central nervous system, it is dose-dependent CNS depressant effect. It decreases the cerebral metabolic rate for oxygen. Cerebral blood flow is decreased and intracranial pressure is also decreased. There is decrease in EEG electric activity. For cardiovascular system, there is modest decrease in blood pressure. But in patients who are hypovolemic, who have coronary artery disease, cardiomyopathy, valvular heart disease, this decrease in blood pressure can be marked. So it is not a suitable drug for induction in patients who have cardiac problems. Pulmonary, it causes dose-dependent depression of ventilation. Also, the laryngeal reflexes are not profoundly attenuated. So there are high chances of having laryngospasm in patients whose depth of anesthesia is not maintained, who are receiving thiopentone. So similarly, there was an endpoint in induction for propofol with verbal response, loss of response to the verbal command. What is the endpoint for thiopentone induction? It is the loss of eyelash reflex. So when you're giving thiopentone, you must have noticed your seniors checking the eyelash reflex, then that they are checking the endpoint for thiopentone induction. The next question is, what are the clinical uses of thiopentone? Thiopentone is used as anesthesia induction drug. Then it is used as a drug of choice for status epilepticus. If seizures are not being controlled with benzodiazepine, then thiopentone infusions are used. Then head injury patients, because it decreases the EEG, it decreases the brain activity on EEG, and it also decreases cerebral blood flow. So it is preferred in patients with head injury or to reduce intracranial pressure, and in patients who receive electroconvulsive therapy also. This is also done because it has a special effect of reverse steal phenomena. So the examiner, if is asking you thiopentone, the examiner will also ask you, what do you understand by Robin Hood effect or the reverse steal phenomenon? So what Robin Hood used to do, he used to steal from rich and he used to give to the poor. So similar effect thiopentone also has. It redistributes the cerebral blood flow from hyperperfused areas to hypoperfused areas to avoid focal ischemia. That is the reason it is used. It is preferred drug in head injury patients, in patients who have higher intracranial pressure, who have severe brain injury. You want to reduce the intracranial pressure. Patients who have status epilepticus, this is the reason that it decreases the brain activity and it avoids any focal ischemia also. So again, next question commonly asked with thiopentone is, what if thiopentone is given intra-arterial? So thiopentone, you all know that this is a very high alkaline pH. So once it is given in intra-arterial, rapid crystal from precipitation occurs. Because of the rapid crystal precipitation, there is vasoconstriction, intense vasoconstriction and excruciating pain in the limb. So patient, and because there is obstruction of the vessel happening, the peripheral pulses may be lost and the limb may go into gangrene. What is the treatment? Treatment is immediate efforts to dilute the drug. You flush the drug out of the system. You give vasodilators to restore the perfusion. The common drugs which are used are injection lignocaine and injection papaverine. So what are the contraindications for thiopentone? Contraindications can be divided as relative and absolute. Relatives are hypovolemia, asthmatic patients because it actually does not obtund the laryngeal reflexes profoundly. Then COPD patients also because they have a reactive airway. So if the laryngeal reflexes are not obtunded properly, they may land up into laryngospasm. Then patients with CAD, that is coronary artery disease, and patients with valvular heart disease. Absolute contraindication for thiopentone are sulfur allergy and intermittent porphyria. Why intermittent porphyria? Because Stimulation of aminolinoleic acid synthetase increases the thiopentone actually stimulates the aminolinoleic acid synthetase, and this increases the production of porphyrins. Coming on to the last of the IV induction agents, this is the ketamine. This is a vial of ketamine. You may get as an ampule also. It is a phencyclidine derivative. It comes as a clear liquid formulation available as a 10 ml vial, 500 milligram in 10 ml vial, so 50 milligrams per ml. Mechanism of action, it inhibits the activation of NMDA receptors, that is N-methyl D-aspartate by glutamate, and decreases the presynaptic concentration of glutamate. And this ketamine causes, what does it cause actually? It causes dissociative analgesia. Dissociative anesthesia actually, not analgesia. It's a typing error. So what happens in dissociative anesthesia? It is characterized by amnesia, intense analgesia, and a cataleptic stage in which the patient's eye remain open and there is a nystagmus gaze. And the patient may have protective airway reflex. That is, the ventilation may not be hampered at all. So various doses of ketamine are IV induction dose is 1 to 2 milligram per kg. Maintenance of anesthesia is 30 to 90 microgram per kg per minute. It can also be given as oral or nasal, through oral or nasal route as a pre-medication dose in the dose of 6 milligram per kg. Intramuscular dose of ketamine is 4 to 8 milligram per kg, and analgesic dose is 0.1 to 0.5 milligram per kg. Infusion for pain relief can be given as 3 to 5 microgram per kg per minute. So long back, when the oral or nasal routes were not available for ketamine, the pediatric population used to receive injection of ketamine intramuscular mixed with the anticellulose agent as in glycopyrrolate or atropine. Pharmacokinetics, it is metabolized in liver by N-demethylation by cytochrome P450. Non-ketamine is the active but less potent metabolite formed, and it is excreted through kidneys. Onset is again 30 to 60 seconds via IV dose and 2 to 4 minutes via intramuscular dose. Duration of action, if given IV, single dose is 10 to 20 minutes, but it may take as long as 24 hours for the patient to recover from ketamine. So it does not provide any clear head recovery. So what are the systemic effects of ketamine? We all know that it causes cerebral vasodilatation. Central nervous system, it causes cerebral vasodilatation. It increases the oxygen consumption. It increases the cerebral blood flow. It increases the intracranial pressure. So it is relatively avoided in patients who have intracranial diseases. For cardiovascular system, there is a sympathetic stimulation, increase in heart rate, blood pressure, cardiac output. But in hypovolemic patient, it may have a direct myocardial depression and patient may land up in asystole. So it is also avoided in patients who have coronary heart disease, valvular heart disease, who require a constant, the patients in which sudden increase or decrease in heart rate is unwarranted. Ketamine should not be used. What are the other effects? Pulmonary, it preserves airway reflexes. It has a minimal ventilation depression. It has a bronchodilation effect over the bronchial muscles, but it also causes increased secretions. That is why whenever you are using ketamine, what do you use with it? You use an anticellulose agent, that is glycopyrrolate or atropine. So clinical uses of ketamine is as an IV anesthesia induction, as a pre-medication, analgesic for analgesia, for psychiatric disorders as antidepressant in the dose of 0.5 milligram per kg over 40 minutes. This along with the restless leg syndrome have come up as a new clinical use of ketamine. Adverse effect of ketamine, we all know that it is full of adverse effects. First and foremost, it causes dissociative anesthesia, which is not very good for the patient. It causes hallucination. It increases intracranial pressure, increases intraorbital pressure. It has a sympathomimetic effect, which is not wanted In patients who have cardiac problems, it increases salivation, which may cause aspiration. Then during the emergence from the anesthesia, it causes emergence delirium, that is post-operative visual auditory or proprioceptive and confusional illusions, which may progress to delirium in certain patients in the post-operative period. And it is also reported to cause transient cortical blindness in certain patients. So in the end, I would like to do a quick mock Viva Voce with our postgraduate student, Dr. Gauri. Hello, Dr. Gauri, how are you?
Hello, good morning.
Okay, so we are going to do a quick Viva Voce on IV induction agents.
So,
Okay, so
just a
Dr. Gauri
moment.
is postgraduate student. And
Just a moment. I think this video is not clear. So, shall I run the video from my side? Dr. Nitin? Mr. Gurmeet, shall I run the video from my side?
identify and describe the drug.
This is a vial of propofol. It is a milky white lipid emulsion. It is a very commonly used IV anesthetic agent, intravenous anesthetic agent.
So can you tell me the chemical name of propofol?
The chemical name of propofol is diisopropyl phenol. It is a substituted isopropyl phenol group.
Okay, okay. So what are the other constituents of this vial?
A vial of propofol, it is a 1% aqueous solution which consists of 10% soybean oil, which is a stabilizing agent. It consists of 2.25% glycerol, which is isotonic with blood. It also contains 1.2% of egg lecithin, which acts as an emulsifier. It also contains a preservative known as disodium editate of 0.005%, which acts as a preservative against bacterial growth.
Okay, very good. You very nicely explained the constituents along with their significance. So what is the dose for propofol?
The induction dose of propofol is 1.5 to 2.5 milligram per kg for adults.
Okay.
The IV sedation dose for propofol is 25 to 100 microgram per kg per minute intravenously. Antipruritic dose is 10 mg intravenous, and antiemetic doses again 10 to 15 milligram intravenously.
And that is very nice. What you can do in this is that I had asked you just the induction dose. You can stop at the induction dose and lead the examiner by saying there are other doses also. Shall I explain them? Okay, so that tells that you are knowledgeable enough. So, okay, why do you think, Dr. Gauri, propofol is being used as a very common IV induction agent these days?
Ma'am, firstly, propofol has a very rapid onset of action. And the second point is that it gives clear head recovery post-op. So these are the two reasons why propofol is used most commonly.
Okay, so before propofol, which was the most commonly used IV induction agent?
Thiopentone sodium was most commonly used before propofol.
So can you tell me which class of drugs does thiopentone belong to?
Thiopentone is an ultra short acting barbiturate.
And how does it come as commercial preparation?
It comes as an amorphous yellow, whitish yellow dried powder, dried hygroscopic powder.
Okay, and why is it yellow in color? You said whitish yellow hygroscopic.
Due to the presence of sulfur molecules in them.
Okay, and what is the pH? What is the pH of sodium thiopentone?
Sodium thiopentone is highly alkalized. pH is 10.1.
Okay, so last quick question. What are the endpoint of induction with propofol and what is the endpoint for induction with thiopentone?
For propofol, it is loss of verbal response, and for thiopentone, it is loss of corneal reflex.
Very good. So this is how the exam Viva Voce may go from propofol to thiopentone or thiopentone to propofol to etomidate or ketamine. So we wish you all the best for your exams and we hope that you have learned from this lecture.
Thank
Good
you.
night.
Thank you, ma'am.
Bye.
Thank you, ma'am. Thank you for such an elaborate lecture on various intravenous anesthetic agents, and a beautifully done small viva sort of helps out the PG students to how to go about answering. Thank you. There are no questions as such in the chat box right now, ma'am.
I think they are all exhausted after such a long, extensive academic session.
I think, ma'am, they have already, I mean, most of the questions have already been answered by you. So maybe
Yeah.
I would go with that as the reason perhaps where there are no questions. So that brings us towards the end of day one of APPEC2023. I hope it was not too exhaustive since we have 6 more days to go. And so we'll end today's session and today's program. Hope to see you all tomorrow morning, 8 o'clock for our day 2 of APPEC2023. Before you leave, there is a button saying quiz on your login page. I would request the postgraduate students to